Well, welcome everybody tonight. Very happy to see so many, I don't see your faces, but so many great names. I'm recognizing a few on the attendees list right now. My name is Rachel Sanner. I'm the digital media strategist at the ACLU of New Mexico. I am a citizen of the Choctaw Nation. I'm also trans. And we're going to be talking about things such as intersectionality a lot tonight. And that's the intersection of two of my big identities. And so I just want to basically preface, set the ground a little bit and get us ready to go tonight. First off, the ACLU, two of our core issue areas are reproductive rights and Indigenous justice. We have 5 core issue areas, those are 2 of them. We have attorneys actually dedicated to both of those issue areas. On reproductive rights, we have Ellie Rushforth, and in Indigenous justice, we have Preston Sanchez. They're both incredible. And oftentimes they're working on their own issue areas, but we oftentimes will see our attorneys work across issue areas because, as with so many things, our identities intersect so closely. So we're excited to have our panelists here tonight representing 3 incredible organizations, 3 incredible people representing 3 incredible organizations. Just want to introduce everybody across on my screen from left to right. First off, we have Corinne Sanchez from Tewa Women United. How are you doing, Corinne? Uh-oh.
I'm like, very good, thank you. Glad to be here with everyone.
It's great to have you here too. Next up is Rachel Lorenzo from Indigenous Women Rising. How are you, Rachel?
Good, thank you, Rachel. And
just for everybody, so everyone knows, Rachel is my favorite because she does share my name, so I enjoy that about. And also, lastly, we have Tara-Lene Massey from the Southwest Women's Law Center. Tara-Lene, how are you?
Doing good, thank you, Rachel.
Thanks. Okay, so tonight, just to kind of tell you where we're going. First off, we're going to talk with each of our 3 panelists about what their organizations are up to, what they're up to as individuals, and just really get to know them and their work a little bit. And then our second part, we're going to talk with each other and go a lot deeper into this issue area and really just get to the, I guess, the meat and potatoes. I'm trying not to use the old Okie saying since I'm from Oklahoma, but that's probably a fruitless effort. So, and also during our free-flowing discussion, the second part of our discussion, we'll be taking some audience questions too. So if you want to, be sure to use that Q&A box. We'll be checking it and I will be forwarding along any questions that we get. So with that said, one last thing to wrap up, we will also be connecting with each of our folks here and they'll be letting you know how you can connect with them and get involved in their work going forward. So to get this started, Rachel, since you're my favorite, since we share the same name, let's start with you. First off, let everybody know your pronouns and then talk about your position, where you work, and what you're up to.
Yeah, thank you, Rachel. I use they, she pronouns. I am one of the co-founders of Indigenous Women Rising. I focus on our abortion fund. So we fund abortion for Indigenous people all across the United States, where we are the only Indigenous-led and centered abortion fund in the country. And we're part of the National Network of Abortion Funds community. So we work very closely with other abortion funds. And we have to, because a lot of our callers are, like I said, they're from all over the country, and not every state has an abortion fund, but we can connect them with funds and help them fundraise for their abortion, which is really sad. We shouldn't have to do that. We also have a midwifery fund. Right now we're piloting this project. We are funding 3 Indigenous people here in New Mexico who have decided to carry their pregnancies to term, and we pay for the midwife that they choose and the doula if they choose to have one. And we also help with groceries, any kind of co-pays they might have, medications that they need to take during their pregnancy and postpartum. If they need to get prepared, with diapers and clothes and baby things, we pay for that with this fund. So every patient, we have had 2 so far, and it's been so successful. And part of that program is to also ask midwives to take on Indigenous students for their hours and help Indigenous people complete certification to become a doula if they want to pursue that, or at least get experience with a midwife or an experienced doula who wants to practice. And then we have our sex education program, which is led by Nicole Martin. And really briefly, our midwifery work, our birth justice work, that's led by Malia Luarki. So with our Indigenous sex ed program, this curriculum meets all of our state requirements, and of course we go above and beyond. This curriculum reflects and centers Indigenous families. For us as Indigenous people, multi-generational homes are very much the norm. My husband grew up with his grandma and grandpa, his parents, aunties and uncles and cousins under the same roof, and that's how we've lived for generations. And so a lot of times we have grandparents raising grandchildren, or aunties and uncles raising the children in their lives, and they might not have the tools or the words to talk about sex or sex education or consent. And so we provide those tools and root it in nearly universal traditional values. I'm just really proud of the work that we do, but those are the three main buckets of work, of course, with advocacy, grassroots lobbying, and community organizing with folks from all over the country.
Thanks so much, Rachel. Tara-Leigh, we're going to go to you next. So just your pronouns and your organization and what y'all work on.
Yeah, thank you, Rachel. So that means I'm your second favorite person. I'm just kidding.
No comment at that after one.
Well, my name is Tara-Leigh. I go by she, her, hers. And I'm the executive director for the Southwest Women's Law Center. I've been in my position since January of 2019. It's almost been 2 years. I am, our law center works on a couple major buckets: gender discrimination, reproductive rights, and also economic security for women and girls. So those are the three areas. What we're doing right now in terms of economic security is we are pushing a paid family and medical leave bill. We're working with Representative Chandler on that bill. Last year, we worked on a pregnant worker accommodation bill, which passed during the legislative session with the help of our partners. And in terms of reproductive rights, we are looking at several major things. One of the big things that we worked on, and I had Dakota send out a link to individuals who signed up for this, is that we did do a survey on how Native Americans feel about reproductive rights here in New Mexico, including abortion. So those are one of the things that we're doing under the reproductive rights umbrella. And then in terms of gender discrimination, we are a very small legal services office as well. And so we provide legal advice and counseling, but we are also, looking for certain cases, certain type of high impact cases. So we keep our eyes out for that too.
Awesome, thank you so much, Corinne. I guess I'm just so everyone knows I'm actually going in alphabetical order, but Corinne, you're up next.
All right, thank you. Uviak Gindi, everyone. Wawaku na okoapepoviomu na pofoge owinge iwiriomu. So I'm Corinne Sanchez, Director of Tewa Women United. Okuapepovi is my Tewa name. And it's a real honor to be here with all of you tonight, sharing your evening. We are just entering our winter break. So I'm here, and Jessica Lujan Garcia Lujan is also on this panel, I see. I'm switching between my glasses and not glasses because I can't see close. And so, but I also don't want to, I also have stuff on far away things on the screen. So yeah, just a little bit information about Tewa Women United. We've been around 30 years. We're a multi-issue organization. We started out as a support group for women, and we now focus on multi-issues. So environmental justice is one of our primary focus areas, or one of our founding areas. Sexual violence, in particular gender justice. So we also provided sexual assault services for 20 some years. And then we have our Women's Leadership and Economic Freedom Program, which also looks at prevention. Well, wait, I'm getting confused. Our Indigenous Health and Reproductive Justice Program, which focuses on our doula program. So we developed a doula program from the ground up some 10 years ago. We do some community participatory research to really inform the development of our programs, and so have been training doula, community doulas, and now we are offering our own doula training program, which is developed with the voice of a lot of doulas, midwives, community members, practitioners in different levels to really help inform that. So we're a trauma-informed in our work and in the ways that we operate. We're also umbrellaed under healing justice. So healing has always been a part of the foundation of our work. As you can imagine, looking at historical trauma, intergenerational trauma, and individual complex trauma, and then also how those inform various experiences, from our sexual violence experience to our birthing experiences. And under our Women's Leadership and Economic Freedom Program, we have our Otging Healthy Sexuality Body Sovereignty Project, which we've been developing and offering in middle schools and 5 school districts around, really, again, healthy sexuality, right? So if we want to really end gender-based violence against Native women, girls, and all women and children, we really need to talk about the positive ways that sex and our healthy sexuality impacts us. And so have been doing that. We've reached over 367 young people. We have trained community-based facilitators as well as youth facilitators. So just a few of the projects that are programs and projects that we have. And tonight we really want to stress, I think Jessica Riggs pushed me to really talk about making full doula spectrum care a norm rather than an exception, that we want to increase in this time of COVID. We've been limited to how many people can go into the hospitals, especially doulas and birth support for our families. So we want to make sure that we always have more than 2 people present for our birthing families. And we want to center survivor care. So as Indigenous women, 1 in 3 of us will experience sexual violence in our lifetime. So that impacts all areas of our life, from our intimate relationships to our birthing experience. And so we've really had our doula program develop from that perspective of being really survivor-centered and trauma-informed. So really wanting to make sure that that's also the norm, because we know that sexual violence and gender-based violence is rampant in our communities, and it's at epidemic levels for child sexual abuse. And so again, how do we make sure that our survivors are at the center of our care? And because of also COVID, and we're seeing really mental health issues, we really want to stress the postpartum care and support for our families and our communities and our birthing parents. COVID has highlighted for us a lot around the stress that this is putting on our families and our communities. And so really wanting to stress that. So I'm here tonight wanting to help answer some questions and learn from these other participant panelists, because they're just amazing just in the few minutes that they had to share. Looking forward to learning and sharing together. Thank you.
Yeah, I want to forth that everybody on this panel are just amazing people doing some incredible work on the ground, each of your organizations. It's incredible what you're all doing. We're moving into the free-flowing discussion. We're going to talk with each other about all the issues that we just talked about and more. I just want to preface, 1 hour is not enough. We're not even going to come close to this is just an introductory discussion. If this really gets you intrigued, there are so many resources out there. These three organizations in particular will have lots more to say in the weeks and months and years to come. So with that said, if you are wanting to ask a question, feel free to do that in the Q&A section or the chat right now. I will get to that, but I want to actually start off our discussion. Corinne, you actually mentioned it. I mean, it's in the room. COVID is in the room with all of us right now, and there's no escaping it. What are some of the things that you have all seen in this era, honestly, that, I mean, what has it changed? What has it not? What has it highlighted that was always there? So let's start with you, Corinne, since you mentioned that to start.
So I think in this time of what we're seeing and what we've always known is the structural racism that exists in systems, right? Systems that have been meant to support us have often damaged us in a lot of different ways, and we see that in our birthing practices. So in 1945 and the 1940s, when the medical model of IHS came into our communities, it stripped that Indigenous knowledge from our communities, our midwives, our birth support people, our community relatives, right, that provided that care. And in this time of COVID, what we're seeing, and I want to say, the trust responsibility of our government was to provide healthcare for our Indigenous peoples. That's treaty rights. And we also know that that has been totally underfunded since the beginning. We also know that the government has also taken our children away from us, you know, and so this reliance, you know, that they've created for us on them, dependency, and also stripped away, you know, our self-determination and our sovereignty. And so this reclaiming of birth justice has been just that, about reclaiming our ancestral knowledge, our experiences as women, our ability to give birth, our ability to give voice around our bodies, and who can give consent, and all of those things. And so I think we started our doula program because IHS, you know, at the time we were developing, had shut their OBGYN in Santa Fe. And so for us to really begin developing our doula program was around that particular incident, but we were really listening to our mothers as they shared in a survey in 2003 about their birth experiences, and that helped to inform our work. The cultural knowledge that was taken, so that cultural congruency that was disrupted, right, because of the federal impositions and the strategic policies that they have around genocide. And so I feel like in this moment of COVID, we've been having to adjust our services from face to face, which is the way we relate to our relatives, to this virtual world. And so that shift has also been stressful and straining for us. All of our curriculum, which is given, you know, in that classroom environment or in a circle environment with our women and our families, is now virtual. And so how do we deal with that, especially also because our rural communities have a lack of infrastructure as far as broadband. And so, yes, we can say that we can transfer and do everything online, but there's still a challenge in our communities with a lack of services. And so I feel like that has been really highlighted in this time. And I'm sure Rachel and Charlene can expand on.
Yeah, thank you for that, Corinne. One of the things that COVID has done is highlight the fact that, you know, not the amount of money we've been underfunded is barely scratching the surface, right? It's over $6 billion that Indian Health Services has been underfunded. And one of the issues that a lot of folks who have never, who don't know what Indian Health Services is or have never gone to Indian Health Services, is that there's no consistency as far as what kind of care is provided at an Indian Health Service hospital. And that's partially due to some agreements that tribes have with the facility that serves their community. And the IHS that I grew up with, which is located at Acoma Pueblo, called Acoma Laguna Canancito, does not have, well, now there's no emergency care, which is super concerning. But when I was growing up and even as an adult, there was no consistent emergency care, no consistent urgent care. The dentist there did a rotation between the hospital, a dental clinic in Laguna, and then Tohajali, I think. And you would have to wait about 6 months, 3 to 6 months to get seen for basic dental care, or come to Albuquerque. So that's just an example of how disparate the service can be. When it comes to reproductive health, part of the reason why Indigenous Women Rising started is because people were asking, you know, how can I get birth control, the birth control that I want? How come I can't get an abortion at an IHS hospital? How come I can't have a baby at an IHS hospital? Why do I have to go all the way into a city or to a nearby town where I've experienced racist healthcare? And with COVID, it just made it much more apparent that the infrastructure is lacking, and not necessarily because of providers, but it's the infrastructure, the actual building. It is, oh, thank you. That's my new kitty, Masra. It's because of the infrastructure of the building, of the resources that we have access to. It's a really frustrating time right now for people who are advocates and who are direct providers, because not everyone is on the same page, and there's so much misinformation out there right now that sometimes I have to do the Google search and make sure I'm not crossing a boundary, because I am not a medical provider. I'm a doula, but I'm not a provider. And so being able to guide a patient over the phone or through a text message about, having to cross state lines and doing the research on the state that they're going to for, what their restrictions are around COVID, leaving their reservation. I have had to, for the abortion fund, have had to communicate with tribes all over the country to get guidance on how people can leave their reservations for medical appointments and not risking my client's safety when they're trying to get an abortion, to make sure that their privacy is protected. So that's a lot of coordination between the client, their family, the clinic, the tribe, the city, sometimes the state. There's a lot that COVID has opened up and exacerbated in some ways.
How about you, Taraline? What have you seen?
Gosh, COVID impacted my family. So I come from, unfortunately, personal experience, because back in July, COVID took my grandfather, and that was really difficult because, he's my grandpa, and, his life was cut short by COVID. And I know that there are a lot of Native American families, Navajo families, who are experiencing very similar tragedies right now because of COVID. And for my family, my grandpa was living in the urban area, and it was a multi generational home, and we don't know how it happened in terms of like how the family got infected, but he did have underlying health issues. And that's one thing that, I totally agree with what Corinne said earlier, and Rachel, is that COVID is showing all of the disparities that people of color face. But I think that it also shows the significant impact and the to tribal communities. We see that our healthcare infrastructure is severely underfunded. We don't have enough qualified medical providers or nurses or nurse assistants, who are working in hospitals to provide care. And the equipment that many of our facilities have, they're barely up to par. And and like we, the Navajo Nation has had to transport people who've gotten COVID off of the reservation to other cities, to other hospitals in the cities. And now, right now, where we are at, what we're hearing or what I'm learning is that because of all of the backlog here in Albuquerque with our own state, our own people here, Navajo people aren't able to come to these other off-reservation hospitals anymore too. So it's, it's big. I mean, the good thing right now, at least today, is that the COVID vaccine is starting up, but there's still a lot that we don't know about it. Although I think that overall it's a good start. It's a good step for us as a country in terms of trying to address the COVID issues. But in terms of highlights from the survey that we saw, one of the biggest things that we asked about access to reproductive health services and specifically abortion care, how Native Americans, the respondents, what they saw, basically the biggest issue they saw was like transportation. They didn't have that they didn't know about the providers that are available to give them the services and the care that they needed. And so there's a lot of, in my opinion, and this is just my opinion, is that there's a lot of outreach and educational opportunities that are available or that can be made, but it has to be done culturally appropriate and, done by, in the right way, like in the Indigenous way. So.
Yeah, Rachel said something in the chat that I think, Rachel, I'd actually like you to talk about just a little bit and expand on. Just talk about IHS facilities and continuity of care. I know from my personal experience, I never had the same doctor for more than 6 months going to an IHS facility.
Yeah, that's exactly what I'm talking about. So there were times where I've taken elders to their appointments and they would not have the same provider. And so yet again, having to explain to the provider again what the issues are. Sometimes a new issue might have come up and they'll say something like, well, it's not in your chart. Well, I haven't been able to get an appointment for 9 months. So this happened within the last 9 months and I can't leave the res right now. There might also be a linguistic barrier between the patient and the provider. And I am very fortunate and privileged to have a master's in public administration with a focus on public health, which is essentially learning how a hospital and a clinic is run on the back end. So I know how the insurance works. I know the coding and how the billing goes. And so, but that still didn't prepare me for the level of advocacy that we have to go through for provider or for patients who are needing to talk to someone over again. And it's not just with elders, it can also be with young people or young parents who are trying to get breastfeeding support at an IHS hospital, or just get a wellness check or a pap smear or something and having to re-explain, why you have to get certain procedures done during a pap smear. And part of that has to do with, IHS is considered one of those government facilities that serves underserved people. And that's part of the student loan program, that if you work at an approved facility as a professional, when you graduate from school, that you can get either all of your student loans or a portion of your student loans forgiven. And a lot of the providers that I've talked to at IHS are like, I'm just an intern. There were times where the ER was overseen by an intern for a few months, and then they went on rotation at another facility. So there's no continuity of care, and it creates problems down the road because it delays care. It can make a patient feel very discouraged and puts a patient at risk for exacerbating existing health conditions. And to me, that is, it's such a disservice to not have, to not take that into consideration. And I know IHS does its best, I guess, to recruit providers that are there for the long haul. There's just a lot of factors, and it's essentially putting entire communities' health at risk. And not everyone is fortunate enough to leave the res to go to a provider who accepts their insurance, whether it's Medicaid or small business employer. And Indian Health Services, for those of you who are familiar with insurance, is the payer of last resort. So if you have employer-based insurance, they're going to do everything that they possibly can to not pay for your care until it's like they've exhausted every possible thing. So they'll take that into account whenever they're looking at what kind of services to provide it at an IHS. And a lot of times it's reproductive health that's on the chopping block for what services are not going to be provided at various facilities.
From the outside, a lot of people will always, activists and such who aren't a part of the Indigenous community, they'll talk about the Hyde Amendment, they'll talk about IHS, all these things. But what Taraline just said, I think I would like any of you to expand upon, is the top problem and concern that folks have is actually just getting to care and getting those just geographical barriers. Do any of you want to kind of touch on that and expand upon it?
Yeah, the Hyde Amendment, folks don't know because IHS is federally funded, is included in the Hyde Amendment. Like I had mentioned earlier, there's no consistency in care across the country as far as what kind of care is provided. And OB care, it's very rare at the IHS that I grew up with that you're going to get to see an obstetrician for more advanced reproductive health needs that someone might have. And so back in 2017, I had started a research project for IWR, which I'm going to start it back up again. But I had started calling every medical director in New Mexico for an Indian Health Service hospital and asking them, if you have a pregnant patient, if a patient finds out that they're pregnant at your facility and they want an abortion, what do you tell them? And a few medical directors said, well, I have directed my providers to just say that, you know, you're going to have to Google it because we can't do that here. And I say, okay, do you tell them where they can get an abortion? They say no. But there are midwives and nurse practitioners who will call us on behalf of their patient to say, hey, I have a pregnant patient. They don't want to be pregnant. Can you help them with an abortion? So providers can be directed by their medical directors to not talk about abortion, which puts them at even more risk because they might not know how far along they are, and they might be further along than is allowed for their state to have an abortion. So then they're having to put all of these logistics in place. So that's the impact of the Hyde Amendment, but it's legally, the Hyde Amendment says that an abortion can only be provided in the cases of rape, incest, and life of the mother. But an abortion hasn't been provided at an IHS, I believe, since like the 80s or 90s. So even if someone does meet any of those criterion, they're still not going to be able to get an abortion because it might be a lack of provider or the medical director does not want to take that risk.
Corinne, Taraline.
And I think we're seeing that one because abortion care is kind of outside the medical care system, right? And so really trying to that's why we're saying abortion is healthcare and healthcare for all. And so because of the repercussions of different types of belief systems, we're not training our doctors. And we need to be, right? I think across the board, if we look at women's health care, even mainstream women cannot necessarily get the health care that we need around reproductive justice issues. And that becomes even more scarce within our BIPOC communities. And so we need to really understand like the the hatred of women, I'm trying to think of that word, but I can't think of the word, is so out there in this country. And so our reproductive health, right? Viagra can get funded, but any other type of issues that we have as women are not. They're not taken care of. We're looking at the long-term contraceptives, and this is where I go, like our communities, though we get this free healthcare, are also experimental grounds, right? Thing for COVID is rolling out. And yes, we want it in our communities. And also there's the same thing of like, I don't know that I want to be the first round of communities that gets this vaccine. We've had forced sterilization within IHS facilities because other people's perception of who we are, that institutionalized racism that exists within those structures. IHS is a military system. When you go to IHS, you'll see people in uniform, right? And so again, they're militarizing our communities. They're looking at those different aspects. And so access is huge. It's huge for all of us to think about where we're getting our care, who's giving it to us, are they trained, do they have a cultural background in understanding these different approaches? We may get free contraceptive because I can go to my clinic here and get free contraceptive, but is it really a contraceptive that you've had a lot of research on, that you have a lot of understanding? So you talk about coercion, you talk about really listening to your families and your communities. I think, again, these systems are really challenging for that. Our pregnant women, you know, when IHS closed their OBGYN, I want to share this, was the first time that I went with my other relatives to go give birth in the birthing suite. Until then, I didn't know what our families were missing out on, because when they were going to IHS, it was a sterile white room. There was no pictures, no images. There was just the dilation chart. Nobody could go in there with them. And then you go to a Medicare paid birthing wing, you know, where they could go to a different hospital, and you saw that birthing room. You saw that birthing suite, right? And so again, we don't know what we're missing until we experience other options. And so if this is the only thing that has been given to them, then that's just what we then settle for. Around how do we advocate quality healthcare, and how are our doctors being trained, and that's the approach that we looked at with our doula program. Services, but there were not any culturally congruent doula programs. We conducted a community-based research, participatory research, in order to gather information from our families and our community to then inform that work. Again, people assume that we as Native people don't have the forethought or the ability to do this.
Uh-oh, we lost Corinne. So Tara-Lene, I know you were about ready to jump in there too. So why don't you take it over for a second?
Yeah, I just wanted to add that, you know, in my last job, I was the social services director at the Navajo Nation. So I went up to a lot of federal meetings with the Indian Health Service and a lot of the Health and Human Services departments. And what I didn't think about this at that time, but now lately I've been reflecting upon just like what I heard, my observations. And some of the things that I've learned is that, or that I picked up recently, is that I don't mean to be offensive to anybody, but I really don't think that our leaders, federal and tribal, really push reproductive services and rights for Native women. I think that's what it is, because I've seen it where, you know, if the tribes decide that this policy area is going to be the focus, like Indian Child Welfare Act, it will be, and they will pay attention to it, they will address it, they will look at it, and they'll study it. The federal government will do that. And here, what I'm seeing, what now that I'm thinking about it, is that I haven't seen that. Like, I've never seen that with tribal leaders. I don't know if it's because they think it's a women's issue, or they're scared to touch it because they're not comfortable with it. But that was what I wanted to add, is just that I don't think that we are pushing, the tribal communities are pushing tribal leaders to say, this is what we want. And this is why it should be prioritized and it should be funded. So that's what I haven't seen.
Caroline, yes, finally, someone else said it, not us, which is why my Pueblo's government is probably not super happy with me. Yes, you can eat that. Sorry, I'm not sorry. I have 2 children. So yeah, our tribal communities, our tribal governments, many times are created as a reflection of the federal system, which are not, like, those systems are not traditional for us. And at least in my Pueblo community, I'm Laguna Pueblo and Mescalero Apache, women, femmes, trans folks, non-binary folks all had a role to play in governance of their bands or their pueblos or communities. And we don't see that. Laguna is a great example. We have something like the executive branch, legislative, and judicial. We have our own tribal court system. Caroline is absolutely right. When it comes to those 638 contracts, the tribes do have a say in what kind, they have some kind of influence, and a lot of those tribal leadership positions are not filled by women, or in my community that I know of anyone who's gay or bisexual or a lesbian, we have 1 woman on tribal council because that is what is legally allowed. And so our health is not being prioritized. And I think that says a lot about colonization, patriarchy, and white supremacy, that while there are no white people on within our tribal governance, as a tribal government, they have internalized a lot of those values around patriarchy. And they're the ones who play ball with the federal government, created by white men. So yeah, thank you for saying that, Caroline. I think that is something that is absolutely missing from conversations about what kind of healthcare is provided. And until we start talking about rematriation and land management and stewardship and tradition, we're not going to get to a point where we can start in realizing and actualizing communities that are healthy and have all of the resources we need, because we're the ones who are leading it.
I just want to +1 what you said, Rachel, and expand upon it. Actually, as a trans person, my tribe, the Choctaw Nation, were led by almost completely universally men. And the simple fact is, as a trans person, the minute I came out as trans, my marriage quit being recognized by my tribe. And also changing my gender marker or my name is just like you're talking about an impossible task, like, for me. And that's because of those influences. My tribe colonization is like, you want to talk about colonization, look at the Choctaw Nation. So yeah, I mean, it's real. It's across issue areas. It's intersectional in those ways. Like, I mean, we haven't even talked about that sort of healthcare for trans folks, but it's also just incredibly difficult within IHS. So I just want to be mindful of time. We were wanting to make this a 1-hour discussion, which means we're coming up on time. From any of our panelists, I know, Corinne, you were kind of cut off. Did you have any other points to add before we move on? I want to be very mindful of that.
No, I think the points that Rachel make around the patriarchy and the impact on our health is key, right? We do need to have more of our community voices in the circle, and we also need to expand our idea of what healthcare is and what does it incorporate. We were on a panel earlier today talking about this very thing. It has to be holistic. It has to look at our ecosystem. It has to look at, where we live, work, and play. and all of the accesses that exist around our communities, and who is a gatekeeper, and how do we continue to push back against this patriarchy. I'm like, it's very clear with this administration that we are finally voting out how much of a challenge it is for our women, our survivors of sexual violence, to be seen, to be heard, to be recognized, and to be able to hold people accountable. And within our free system of IHS, we lack the ability to also hold those who have mispracticed on us, right? Who have malpractice suits and things like that. Again, I feel like because we're poor, we're the experiment, and people can experiment on us in all kinds of ways. And so again, how do we get our community voice and our collective voice to those circles? And thank you for the ACLU for holding this panel, because this is one way for us to be able to do that.
Thanks so much. I just want to point out one thing that very important, I think. We are moving into a new administration, but the problems we're talking about here, they span multiple administrations. Just because Trump is out of office on January 20th, these problems are not going away. So it's more important than ever for folks to find ways to get involved, to raise their voice, and to ally with each of these organizations. We can't, just to opine for a second, this is not the time to sit down and let the world pass us by. This is the time to rise up and actually enact change in the country. This is the only way we're going to do it, is if we actually push forward right now. So I want to give our panelists one last chance to talk about this issue before we wrap up. So I'm going to go in reverse alphabetical order this time, and I'm going to ask everybody the most famous question of all: what is the one thing that you want people to take away from this discussion tonight? And Corinne, that means you are first.
I hope just in this small discussion that you see and hear the challenges that we face as Indigenous women, to hold not only our communities accountable, but our governmental and governancing structures that provide service to us. And the only way that we can do this, when we represent only 1% of the population in the youth system, is that we have strong allies on all levels to help lift up our voice, to help us leverage change and transformation, and to listen to us, right? If we're not at the table, we depend on you to bring our voices to the table. And the only way that you can do that is if you're listening to us and you're in relational activity with us, to hear what our challenges and our concerns are. And we appreciate all, we've been here 30 years as an organization, one of the few women's led organizations in this state. And now we see this movement and momentum where women rising, Indigenous women rising, and other women's organizations are coming to be. And that's a powerful place for us. So we need to continue to work together collectively to put pressure and to transform, because it takes all of us to do that. So thank you all.
And how can people stay in touch with your organization, Corinne?
You can visit our website, www.tewawomenunited.org. We have a Facebook page. We have multiple Facebook pages for our program areas. So just please contact us. We're on winter break right now, a well-deserved winter break, I might say, for our staff. And we'll be back January 11th. But yes, please contact us in those forms.
Thanks so much, Dakota, for sharing that URL in the chat. I was about to ask you to do that. Taraline, you're next. What is the one thing you want people to take away from tonight?
Well, I think for me, we did share our survey, and normally, I've done presentations on that, and it usually takes about 35 minutes to do those. So we gave that to everyone. But if you haven't looked at it, I would highly recommend you look at it. It is very, Indian health / reproductive health 101. So if you want to learn more about the issues that were outlined, it's a good, starting place for that information. And the other is that there are these great partner organizations that we work with, and they deserve to be supported. And I think that would be my main recommendation. I did get a question, and I wanted to answer that as well. Someone was asking me about, just to clarify about the transportation and why that's an issue. What I wanted to say is that in many of our many reservations, including the Navajo Nation, they're very rural, very frontier, and hospitals are far to get out. A lot of people, if you look at the survey, about 50% of the respondents said that they were making under $30,000 per year. So a lot of people don't have access to vehicles, don't have access, to transportation just to get to medical appointments. And so if they can barely get to their appointment at their local IHS clinic, they're also going to have a really hard time trying to make other appointments here in Albuquerque area. And so that's the reason why what Rachel's work is so important, and Indigenous Women's Rising, they help provide some of those resources to people. So, but I just wanted to just clarify that, because I guess it sounded like I was talking about cultural sensitivity, but it was more about just access issues. So.
Thanks so much for that. Terlene, how can people stay in touch with you and your organization?
Yes, we have our website, swwomenslaw.org, and we're also on social media, Facebook, Twitter, Instagram. So that's where we're at. Thank you.
Awesome. And Dakota has shared links to both that slide presentation and your website on the chat. So if you're on looking for that. So Rachel, your last, what's the one thing you want people to take away from this discussion tonight?
That you're on Indigenous land. I know for many folks, it might be like a what moment when I mention land stewardship, land management. I think my day job is I work at the New Mexico State Land Office, and it is through this very colonized agency that I have much more of an appreciation for my culture, for my tradition, my language, the land, that we're all on stolen Indigenous land. And if folks can just take a moment to center us as Indigenous people and think to yourselves, as you are going through your day, as you're making economic choices for you and for your family, thinking about, do Indigenous people on their own land get to make these choices at all, or are they backed into a corner because of federal policy or tribal policy? Everything from buying a home to what school you go to, what hospital you go to, who your provider is, where you work, the grocery stores that you're able to get to. If you can take a moment to center Indigenous people in those thoughts, in those decisions, everybody benefits. You don't lose anything from centering the people who you're it. You don't lose anything by centering us. So when you're going, making these big decisions or small decisions, and just having more of an appreciation that we are still here. We are not the romanticized vision of what Native people are based on the media, like we're still here. Where we are is thanks to Indigenous people. That is the one thing that I want folks to take away, is that you're on my land and I deserve to have healthcare. I deserve to take care of my family. My children deserve clean water and clean air. And if we can center those things, all of us will be a lot healthier and safer.
Thanks so much for that, Rachel. And how can people stay in touch with you and Indigenous Women Rising?
Yes, we have a website. iwrising.org. You can sign up for our email listserv. We're going to be more on top of it because we're tired. On social media, our Instagram is always bumping. So at Indigenous Women Rising, we're on Twitter at IW Rising and on Facebook. And next year, I think, Cole, hopefully, we're going to be expanding our podcast just a little bit more. So keep an eye out.
That's really exciting. Thanks so much to all three of our panelists. You're all awesome. Seriously, thank you for being here tonight. And thank you for everybody who did tune in tonight. I want to gently remind everybody, as gently as I can, that the 2021 legislative session is coming up here in New Mexico. Each of these three organizations, and plus the ACLU, are going to be working on many bills. So check out those URLs, find ways to connect with all of our organizations. And like I said earlier, the time is now to start making a change, and there's no time to rest, and the legislative session in January is the time to start making that happen. So thanks everybody for attending tonight, and we will see you soon.
Bye.
I just want to thank all of the panelists and everyone again. Thank you for attending.